introduction, we know that meningiomas are primarily a neurosurgical disease. And while the majority of tumors are histologically classified as benign, the clinical course and impact on patients and caregivers can be far from benign. The first line treatment we know for meningioma is surgery, followed by, in selected cases, fractionated radiation therapy or stereotactic radiosurgery. So the indications for treatment should always be individualized and take into consideration factors such as age, comorbidity, life expectancy, patient preference, histologic grade, molecular factors, tumor location, and extent of resection. Systemic therapy is largely used in higher grade tumors as a last resort once all surgery and radiotherapy options have been exhausted, but typically results in only modest efficacy. And while the majority of meningiomas have excellent long-term control rates, due to their slow growth, clinical series with follow-up in the range of 5 to 10 years carry the risk of underreporting late meningioma recurrences that can occur decades after primary treatment. So this being said, we're going to talk about surgery. So we know that the surgical gold standard for meningioma. Yes.
Can I just make a comment on the last slide?
Yeah, sure.
I just think for perspective, this is very well stated from the paper, but the field of meningioma, there is no proven medical therapy. And there's, a case report here, a case report there, an immunotherapy worked for one patient, but no one has actually shown a medical therapy, which is kind of remarkable because meningiomas are outside the blood-brain barrier. So when we think about like chemotherapies they've tried, like hydroxyurea, there was just trianotecan, I think, just had a big phase 2 trial, and some others, like there really is nothing that treats these tumors once they start growing, aside from surgery and radiation. And the ones that cause real problems are the ones that grow through that. And I think that the second part that you show is also really important because most follow-up, like even in the studies I've done and things, like if you have 5-year follow-up, you're very happy. But the treatment and actual course of meningioma is much longer. So it's different than glioma, where glioblastoma is going to come in, 2 years, everybody's going to die. This is a long-term thing. And so some of the best studies, there's a few from Sweden or from the Scandinavia area. And when you look actually at 25-year follow-up of meningioma patients, even after Simpson grade 1 resection, which you'll get into in a minute, but a complete resection of a grade 1 tumor, the recurrence rate is over 30%. Or like 25 to 30%. So many of the studies that we look at and the feeling that these are all benign is because in most countries and places, people don't have that kind of long-term follow-up. And that's really important as you guys think about interpreting the literature and understanding meningioma in that process. So anyway, carry on. I just wanted to mention that because I think it kind of tempers how you look at a lot of these things. And also for clinical trials, for medical therapy, a lot of those tumors that they've tried them on are very bad tumors. The meningiomas that are really aggressive come back, and maybe you'll get into some of that in this paper here.
Yeah, sure, no problem. Feel free to interrupt me. I think this is the best part of journal clubs, as you mentioned.
Hey everyone, Ryan Rad here from Neurosurgerytraining.org. If you like that video, subscribe and donate to keep our content available for medical students across the world.